Hello, everyone. Thanks for joining this session. I'd like to welcome you all. My name is Ilyas Harlafti. I am the co-lead for the IBD work package on H2O. I work with Roche. I'm based in Basel. And my co-lead on the IBD work package is Dr. Mark Ferrante of the University of Leuven. I am absolutely delighted to be joined here by a distinguished panel. We have Professor Dr. Jonathan Fiorino, we have Dr. Peter Irving, we have Ingrid Arias, Evelyn Gross, and we will definitely go through a round of introductions in a minute. We're also joined here by Liselot Fierens of the University of Leuven, a fierce young professional who has done so much to advance the work that we are delivering as part of Work Package 4, the IBD Work Package. For those of you that are just joining the May Open House just now and may not be as familiar with the Health Outcomes Observatory, aka H2O, let me tell you that H2O is a public-private partnership. It's a consortium that is funded by the IMI, the Innovative Medicines Initiative. Our goal is to strengthen the patient voice in healthcare, and we take a particular focus on patient-reported outcomes to do so. Today is the second of the 2 days of the May Open House events. And we are showcasing, as you have perhaps seen already from the diabetes session just before, and you will see in the oncology session right after, the work that we have done on the standardization and implementation of PROs, taken a disease focus area, of course. That being said, let me quickly turn to our panelists. The way the session will flow is first we will have Liselot present the latest of the work status, and then we will go into a conversation with the panelists and open the Q&A. Dr. Fiorino, may I start with you? If you may please give a very short introduction and do so perhaps by sharing with us and our audience what intrigued you to participate in H2O.
Hello, everybody. My name is Jonathan Fiorino, gastroenterologist from San Raffaele University in Milan, Italy. And I'm very glad to participate in this project because since several years, I engage my patients in all aspects of daily practice, management, and so on. And I also led a consensus from ECHO about the standards of care and how to standardize our approach to IBD patients. And I'm proud to say that I was truly convinced that patients should be part of the panel of ECHO guidelines, ECHO position papers, because patients should tell what is the best for them. So this is mainly the reason why I was so happy to participate in this project. I think this is the best synthesis of the work that we clinicians, patients, and all the healthcare professionals do for the advance in IBD care.
Thank you very much. Thank you so much. Up with Dr. Peter Irving. Peter, are you with us?
Hi, yes, I'm Peter Irving. I'm a consultant gastroenterologist from London, from Guy's and St Thomas's, you know, I think my interest about this program really comes from the fact that traditionally healthcare has very much, particularly the language of healthcare, has been driven by doctors and not by patients, and you know, and particularly those of us who work a lot in clinical trials have seen this evolution of outcomes that for a while was driven really entirely by, I guess, medical and scientific outcomes, and now there is an increasing realization of the importance of patient-reported outcomes. So, I think this is a fantastic initiative, and I'm very pleased to be part of it.
Thank you, Peter. Thank you indeed. Perhaps we can move on to Ingrid Aris. Ingrid, I hope I've pronounced your surname halfway correctly.
Hey, good afternoon, everybody. A bit of my background: I'm the Senior Clinical Project Manager of the Belgian IBD Research Development Group, and I have almost 20 years Crohn's disease. So I had a lot of interactions with clinicians and IBD nurses. And I see that it is very important that the role of an IBD patient takes an important role in the clinical decision. And that's the reason why I participated in this project, because I think it's important to listen to the voice of the patient. And it will also lead to a better interaction with the healthcare professionals.
Thank you very much. Evelyn, on to you.
Hello from my side. So thanks for the invitation, and happy to be with you and with the audience who is interested in. My name is Evelyn Gross. I'm from Austria, and I'm the president of the patient organization. As I suffer for more than 30 years of Crohn's disease, there is much to improve, and this is a very, very important step, because we can improve quite a lot with the interaction with our doctors and the healthcare professionals. So I'm really happy that this project has started, and I'm happy to be part of it and that I can contribute to it.
Fantastic. Thank you very much, Evelyn. Liselot, on to you for a short introduction, and then you can take it away with a presentation. Thank you.
Sure. Thank you, Elias, and thank you to all the panelists for joining us today. Briefly about myself. My name is Liselot Vierens. I'm a PhD candidate at the Catholic University of Leuven in Belgium. And I'm also highly involved in the H2O project from the Leuven side. So I will present to you today the results of a Delphi exercise we conducted in the beginning of this year. And hopefully this presentation will spark some interest amongst you, and maybe also some questions, which you are, of course, more than welcome to pop into the chat box, and will then be discussed by our expert panel later on. So please do that if you have any comments or questions or challenges we might face as well. Okay, so about the project itself, if you have attended the previous open house sessions of today or yesterday, you probably heard that one of the main H2O goals is to help standardize data collection to facilitate data integration and also comparison, not only within certain disease areas, but also across different disease domains. And so a good way to start off the H2O project was therefore to define a core data set for the 3 different disease areas involved in the project, whilst aligning also the processes to do so, and also by building on existing initiatives that are already out there to not repeat the same exercises. So also, if you attended the previous session, you will have heard the discussion in the diabetes group, and in the next session, as Elias also mentioned, the results of the oncology group will be presented from a very similar Delphi exercise. So in that way, we are trying to align also across disease areas. And in the IBD group, we likewise aimed to develop a core standard set that includes, well, not only the traditional clinical outcomes, but also to be as complete as possible patient characteristics to allow later data stratification, for example. And of course, as also mentioned before, patient-reported outcomes, on which the H2O project tries to focus on, also by including patients from an early step of the process. So, and we try to develop or to build on existing initiatives by holding a multi-stakeholder consensus process, or more specifically, a Delphi exercise. And classically, a Delphi exercise starts by looking into literature, what is already out there, especially for IBD. We looked into existing initiatives and how we could build on these instead of repeating the work and trying to go into dialogues with existing core outcome set initiatives, for example. And based on these findings in literature, we were able to compose a preliminary list of less than 100 items that is feasible to send out in a Delphi type survey online. So this survey was then sent around online in 2 voting rounds, in which we asked a number of IBD stakeholders to score the importance of this list of items. And by IBD stakeholders, we not only included healthcare professionals, but also put a lot of effort on finding as much patients as possible who were willing to participate. And then also we included industry experts and regulators in this Delphi exercise. And now hearing these 2 last groups, you can probably immediately think of reasons why we should include these groups as well. But going through literature, we noticed that this is not commonly done. So in that way, we think that H2O can bring a lot of added value by including this multi-stakeholder approach. So after these online Delphi voting rounds, we also invited a selection of the Delphi participants to participate in an online consensus meeting, in which the results of the Delphi rounds were discussed, and also where we agreed on the final core data set for IBD. Then on this first result slides, you can see a schematic overview of the literature review. So we decided to search the most appropriate databases for relevant articles, and we were able to identify 3 core outcome sets that already exist for IBD, and also 7 appropriate or relevant review papers. From these articles, these 10 articles, we extracted an abundance of outcomes, also, of course, taking into account the outcomes that are currently being collected already in the implementation sites, because we didn't want to neglect the work that is currently being carried out there and that has already also been carried out to select these outcome sets locally. So from this abundant list, we were able, after refinement and discussion in the core team, to further define or select 85 items in total that would be sent out in the Delphi voting rounds. Then on this next slide in the table, you can see an overview of the participants that participated in both online voting rounds in the Delphi exercise. So you can see that in total, we had over 130 participants participating in both rounds. And this was a mixture of mostly healthcare professionals, but also almost 50 patients participated, or patient advocates. And we also had, as I mentioned, a number of industry experts and regulators participating. You can see that almost in all groups or stakeholder groups, more females, more women participated. And in the healthcare professional group, you can see that we had a good representation of researchers and also gastroenterologists. But then we also had some other very important disciplines that participated in both Delphi rounds. Then for the patients, you can see that mostly highly educated patients participated in the Delphi exercise, and that we did have a good, fairly good representation of both Crohn's disease and ulcerative colitis patients represented. Then in the next 3 tables that I will show you, you can see the list of items that made the final core data set for IBD. So these are all of the items that eventually came out as most important out of the Delphi exercise. In the first table, you can see that the 18 case mix variables that made the list. And in the first column, you can see the title of the item, so very brief description of the item. In the second column, you can see the person that will report this information or provide this information. In the third column, you see the percentage of agreement, meaning the percentage of participants that gave this item a high importance score in the Delphi exercise, meaning that they gave the item a score of 7, 8, or 9 on a 9-point likelihood scale of importance. And then in the last column, you can see the origin of these percentages. So either the percentage that was reached in the second Delphi voting round or after the consensus meeting. In this second table, you can see the clinical outcomes that made the final cut. So 13 items that relate to clinical outcomes, survival and disease control, for example, but also to outcomes that relate to healthcare utilization, and also one item that is related to adverse events made the final cut. Then in the last table, you can see that 17 patient-reported outcomes related to symptoms, function, and quality of life made the final cut, and also one patient-reported experience, namely therapy satisfaction, made the final list. Okay, moving on to the last slide, I can briefly show you a task overview of the IBD work package in H2O. I just presented you the final core outcome set that we developed. But with our core team, we also want to discuss and also recommend the most appropriate instruments to measure these outcomes, and also to recommend the ideal frequency of measuring these. So that is on schedule for the near future. And then we are also currently preparing task 3, so the clinical implementation of this core outcome set and the measurement hereof. And once the implementation is finalized, we will of course revisit the core data set and refine this as well, so that in the end, once we have the collected data, we will also be able to optimize data stratification and outcome prediction. So as this is my last slide, I hope you find these results interesting. And also, again, if you have any comments or questions, please pop them in the chat box, and we will be happy to address them in the expert panel. So thank you for listening, and I think it's time to give back the word to Elias and our expert panel.
Thank you, Liz, a lot. Thank you for this wonderful summary of our work. Indeed, we do have 2 questions, and perhaps you can take them on. One question is about the stakeholders. So our audience is curious to understand a bit more about who was represented at the consensus meetings. And the second question is whether we have considered adapting one of the existing core outcome sets. And if we did, how did we deal with that? So over to you.
Okay, well, thank you for this question. Yeah, about the consensus meeting, that's a very important question, and I was debating on whether to include a slide or not, but given the time, I was hoping for this question, so thank you. We made sure that all of the stakeholder groups were represented in the consensus meeting as well. So from the start, we composed a core team that prepared the Delphi exercise, conducted and reviewed the literature review and the preliminary list. So in that core team, we had industry experts, healthcare professionals, researchers, and also patients on board, who were all invited for the consensus meeting. And then we also invited additional external participants that participated in the Delphi exercise that are not part of H2O, based on the best geographical presentation and also representation of the stakeholders. So for example, we didn't have any regulators on the core team, so we made sure to also invite additional regulators, and they were represented indeed at the consensus meeting. To give you exact numbers, I think we had about 20 people participating in a consensus meeting, of which 4 patients, and then a mixture of the other stakeholders. And I hope this addresses the question.
Yes, it does, definitely. The second one would be, again, as a reminder on whether we have considered existing core outcome sets. So a brief answer on that. And of course, we can type in a more wholesome answer in the chat as well.
Right, okay. For the existing core outcome sets, we identified 3 as I showed in the results of the literature review. So one being the ICHOM set, and then 2 on a more narrow IBD group. So I think one was on fistulizing Crohn's disease, and the other one was also very narrow IBD group, and only included clinician reported outcomes or clinical outcomes. So we considered all 3 of them. And we made sure to also include all of the outcomes that are listed in those outcome sets, to include them in our literature review, that they were included in the preliminary list, which was ensured. And then we also took into account the outcome sets, or the more in-house developed outcome sets that are used in the implementation centers. So for example, in the Netherlands, they have a very thorough list already existing of outcomes that are being collected all over the Netherlands. So we made sure to also include those into the literature review.
Fantastic. Thank you. Thank you, Liz, a lot. I'd like to move us now to our panel for some more conversation on this topic. And Evelyn, I heard you speak, and Ingrid, you as well, earlier as you were introducing yourselves, about the patient and physician interaction, and how an endeavor such as this one, and indeed the data that we hope to collect out of this entire exercise, are going to help enrich the interface between the physician and the patient. I would like to start with you, and it'd be wonderful if you could elaborate a little bit on that. So, how would you perhaps use such data to facilitate that physician-patient interaction? Ingrid, Evelyn?
Yeah, I will start. So at the moment, there are many medication available for Crohn's disease and ulcerative colitis. And sometimes it's important because one medication has some side effects that the other one has not. And taking the patient-reported outcomes into account in the clinical practice, this can maybe make an easier decision which medication can be taken. And also important in the core data set is it's not only the clinical parameters, but it's also social parameters, the mental parameters that is taking into account, and this is important, which has impact on your relation, on your daily life. And if you can explain this to your physician or to the IBD nurse, it's important to understand which treatment is the best choice for your disease.
Yeah, quite right. And Evelyn, to follow on the thread that Ingrid started here, I'm guessing, and we know already from research and from our interaction as well, that there are topics that people with IBD might be less comfortable discussing during the clinical visits. And would you believe that this opens up, let's say, the space for some of that information to be collected in a more comfortable way outside of that clinical visit?
So I do not hope, I'm sure that will improve, because time is always lacking. And with this new tool, I'm sure there will be more time with better quality of the interaction between doctors and patients, or healthcare professions and patients, because there are so many parameters which are maybe asked on the digital way, which are excluded because they do not matter. And there will be a new time, so-called new time, for both sides to explain more the patient-reported outcomes and to have a better discussion on what's the goal of the patient, what is a patient journey. So regarding pregnancy, regarding education, many of the people are very young and attend to school. So which profession to choose later on. So these are important topics, and I'm concerned that all these topics are related to the treatment the patient will get and needs, and so we can adopt and to define common goals and look how to achieve those goals. Because on the other hand, maybe the patient doesn't understand why the doctor wants my mucosa to be healed. This is something I do not understand what this for, or what about is this to help me in my daily life. But if there is a common goal and we can achieve together, this would definitely be great. And if you have more time to discuss such wishes and goals from the patient, this is of added value. So we hope we can achieve this.
Yet thanks Evelyn for that perspective. Yet, the most perfect plan can crash, when it's confronted with reality. And here I want to draw in the perspective of our medics, right? The perspective of the clinician. I'd like to start with perhaps you, Peter. We all know the stress and time constraints that physicians out there in real world clinical practice are facing. How realistic is it for us to expect, that a physician that has many consultations and visits in their day is actually going to go in, look at all of the data, and then be prepared to go into that conversation with a patient?
Yeah, I'm glad you asked that, because whatever it is that I wish to happen isn't the reality. And the reality is, of course, that if you look at the entire core outcome set, there is absolutely no chance in most healthcare systems that you will be able to address the entirety of it. That, of course, doesn't mean it's not a worthwhile exercise, far from it. It can help us to focus on areas that are important, that may vary from time to time. I think it's also important to remember that that data creates better understanding of the totality of the disease, and that's part of what this is about in my mind. Is that, of course, we're not just concentrating on things like mucosal healing, but we're concentrating on things like mucosal healing and perhaps ability to go to school, and I didn't see it mentioned, surprisingly, but sexual function, or or tiredness, and these things, and these things are not unrelated. They're commonly closely related, or at least partially related. And if we put all of this together, then it enables us to understand that relationship better. So it's really important to remember just how limited time is, unfortunately, in many healthcare systems. But then we need to work out how we can use these sorts of tools to help us in that, as opposed to making it even more.
Yeah, and I love the perspective on focus that you gave, Peter, because every physician knows the person that they have opposite them, in their practice. And so they can choose to focus on those specific aspects as they follow the patient, through the time. They don't obviously need to go through everything as they prep for that. But I wanted to touch also on a different dimension of that, let's say, physician-patient interface. Often we hear, and in fact we know, that there is a so-called black box, especially for people that are doing well, that have been in a controlled phase for quite some time. And then, they don't really tend to interact very much with the medical staff or their care team until things turn for the worse again. I'm wondering, and this is a question to you, Jonathan, to what extent you believe that more or less frequently monitoring the responses that come through the PROs might help the care team. Predict is a very big word, but sort of sense a little bit and keep tabs and keep track of how their patient is doing in between the visits.
Yeah, you're right. I think that maybe a different approach, Peter told, but I can confirm I'm now doing telemedicine, and we usually ask the patient to send a sort of a list, yes, no answer on different questions. And this helps us to be focused on problems of the patient. But on the other hand, the patient is relaxed, can be concentrated and can think about some problems or some issues or some worries. And I think this relaxing time to answer the question and then send to the clinician helps also those patients that are not so, let's say, prone to speak, to tell you some inputs. Look, I have this problem, I have this worry, and then during the visit, you can focus on that. And of course, you should know the patient. You should know how it behaves, how he or she behaves, or how he interacts with the staff. But I think that this set, we discussed a lot to have a set that could be simple for the patient, and as much as possible have only very simple questions, yes, no, with simple answers. Because in this way, you can have a direct look at the problems, the issue, and then you can focus on that to solve. And also, it's also very easy to measure after any intervention.
Fantastic. Thank you all for the answers you've given here. I'd like to switch gears to a separate, let's say, element of value that we all see in H2O, and that is data for research, right? One of the ambitions of H2O is to create a rich, high quality, dense data set that would be accessible to different parts of the community, be it the clinical research community or even the patient community, for their own research purposes. Here, I would like to start in the reverse with Peter and Jonathan first. What are your, let's say, hopes or ambitions for clinical research based on the data that is going to come out of H2O?
I'll go first then. I think clinical data is incredibly useful. We collect all sorts of data in inflammatory bowel disease, but well thought out and systematically collected clinical data has huge benefit, largely in that sort of real world setting, which is where we often struggle to get high quality data, particularly across different sites. And yet it is incredibly instructive. It's often said that perhaps only 30% or less of our patients would make it into clinical trials, the other 70% being excluded for some reason or another, and that very nicely illustrates the fact that the majority of our patients aren't represented by the data that are created from clinical trials, and yet we extrapolate understandably from those trials to clinical practice, and so actually having those sort of real world data is hugely influential in what we do. And again, that's why the whole PRO side of this is so important, because it's looking in a much more holistic way at disease outcomes. So the opportunities are endless, but it's all down to the quality of the data collection. So I think
we're all looking forward to seeing the first data come in so we can all jointly assess the quality and usefulness of that. Absolutely, Peter. Jonathan, a comment from you, perhaps.
Yeah, it will be very important because there are some problems now in research, especially for small centers or centers that don't have so many fundings. First, the companies are the main driver for studies, and they choose the outcome. On the other hand, for spontaneous studies, many times we don't have the data that we need. And at the same time, clinicians choose the outcome. So in this way, we have a full set of outcome measures that are shared with patients, stakeholders, and all the actors in this panel. And second, we could systematically collect this data, and probably we will discover a lot about the complexity of the impact of IBD on patients that are not only bowel movements, abdominal pain, and hemoglobin. So I think this will open a lot of new fields of research in the next future with simple data and just reported by the patient.
Fantastic. Now, I'd like to turn to Evelyn and Ingrid, because I think most of us, when we think about research, we think about clinical research and clinicians, you know, taking the lead on research. But what we see is an ever-growing trend, which we welcome absolutely, the so-called trend of patient-led science, right? We see more and more, and that's fantastic, you know, people that are active in a certain disease space, who are perhaps, you know, living with a disease themselves, who take on joint research efforts on data that becomes publicly available. How do you see that movement developing, and do you see this happening in the IBD space?
So maybe I can start first. We have a lot of surveys in Austria, small surveys, and we see that the other IBD patients are really interested to answer those, to give their inputs to it. But I think we still have to educate the patients that he drives research. So we are far from that, but it's the right direction, I think. For me, the most important thing is if we collect data, the data is not only important for research, it's also important for me, for myself, because you never know when was your last flare, and you also want to compare. You want to compare the numbers of the stool frequency, of the pain, of whatever. So you also have a benefit out of that if you have access to the data. And I really do hope that we will come to that mind of the patients, that they are willing to share their data. They trust in data protection, of course. And so, like, I just see it nowadays that when I am asked if the rest of my blood collected or other tissue collected, which is not used anymore, can be used for a biobank. And if I see the patients, they are really willing to agree. But for giving away those data, we are not used to that. We're not educated so far. But I think this will come, and then we are willing to contribute to this and also to drive research, hopefully.
And Ingrid, your comment. Thanks, Evelyn.
So my main comment is that there will be a harmonized and standardized data a tool available is to assess this, and that it will be used global. I think this is important for the patient, because at the moment many tools are sent and possible to complete many questionnaires, but it would be good to have one tool that's supported at global level.
Absolutely, the effort on standardization and of course adoption.
I think we are losing, or we lost Ilias. All
Yes.
right.
Liselotte, can you moderate this?
Yeah, well, I think our session is almost ended also, but is there anyone who has any remaining questions maybe we still have to address, or remarks, concerns? Well, then I would like to thank our panel for joining us today, and all of the people participating and listening, and also sending in the questions. If there are still unanswered questions, I'm sure we will address them after the session. So thank you all for joining.
Thank you. Bye.
Thank you.
Thanks very much.
Bye. Bye-bye.
Bye-bye.